going to go through quick lah sekejap. Okay lah, boleh. Next. Next lah. Sorry, tak ada cover lah, tak ada quiz apa-apa. I didn't prepare anything anyway. So, definition. Okay, so basically, neonatal sepsis is a syndrome. Okay, again, it's a syndrome, means it's a collection of symptoms and signs of infection with or without accompanying bacteremia. So basically, sepsis, neonatal sepsis is defined as any features that suggestive of infection with or without bacteremia. Maksudnya with or without positive culture lah. When you say bacteremia means there's a positive culture. So with or without positive culture in the first 28 days of life. Okay, it can be septicemia, can be meningitis, pneumonia, arthritis, can be anything. So these are the source of infection. Okay, epidemiology. So this is one of the most commonest cause of neonatal mortality. Okay, up to 30 to 50%, and up to 20% of neonates develop sepsis. Okay, next. Okay, again, it occurs in 1 to 5 per 1,000 live birth, especially in low birth weight lah. The smaller the infant, the higher risk of sepsis, and also the younger the infant, means the more premature an infant is, the higher risk of death and also sepsis. Okay, next. So in general, it can be divided into two: early onset and late onset. Early onset means most literature they quote less than 3 days lah. Kalau more 5 to 7 days ni is actually dah quite late. So most literature said less than 3 days. Ada yang kata 24 hours, ada yang kata 72 hours. But most of the time is 72. Less than 3 days we call it early onset. After that is late onset. Okay, why do you have to classify between early and late? Okay, because the culprit is different. The source also is different. Okay, let's go to early onset sepsis next. So early onset sepsis again, as I just mentioned lah. So sepsis occur within the first 72 hours of life. Okay, most infant usually asymptomatic at birth. Okay, sign of sepsis develop usually after a few hours of birth, except in some severe sepsis that occur antenatally and occur perinatally or antenatally. They can present much earlier lah, even at birth. Okay, most common presentation is actually pneumonia. Okay, and the source of infection is actually maternal genital tract. Okay. Occasionally, it can actually maternal infection, the translocate intrauterine. So it's caused the maternal infection cause intrauterine infection, which can lead to infection lah, sepsis in newborn. But most of the time, early onset sepsis occur. The onset of infection is actually during delivery, okay, which is from maternal genital tract. That's why cesarean section has slightly lower risk of early onset sepsis, okay, because they don't get the infection from maternal genital tract. Okay, most common organism, some organism macam I mentioned can cross placenta lah, macam listeria, Treponema, syphilis, and some viruses. Okay, the risk factor is low birth weight or prematurity, febrile illness. So lagi? Tak payahlah. Tak bantu. Okay. So the risk factors is actually low birth weight, febrile illness in mother punya sepsis lah. So in general, the most important risk factor is actually mother punya risk factor. So in managing sepsis, the most important step is prevent sepsis. Okay, because once the sepsis set in, then you have to treat lah, and complication is high. So the most important measures is actually to prevent sepsis. And in order to prevent sepsis, the best management is actually to treat maternal sepsis. Okay, to prevent the maternal sepsis from infection from transfer from mother to baby. Okay. That's why history from OMG is very, very important. Ada soalan ke? Kalau you ada soalan atau tak dengar, you inform kan. So the most important is to identify risk in mother and sign and symptom of sepsis in mother and treat with antenatal antibiotic ataupun intrapartum antibiotic. Okay, so these are the risk factors you can read. Okay, next. These are also the risk factors. Okay, so the one that highlighted lah, yang the most important. Prolonged labor. Okay, for maternal, these are mainly maternal risk factors. For antenatal risk factors, things like perinatal asphyxia is one of the risk factor for sepsis. The next is late onset. Ada soalan tak? Have you got any questions about early onset sepsis? Okay, tak ada, then late onset sepsis. So late onset sepsis is a sepsis that occur after 72 hours of life. Okay, why we differentiate between why 72 hours become the cut-off point? Okay, you pernah dengar, you know what's the difference between nosocomial infection and community acquired infection? Anyone?
Yes.
Apa beza dia?
Beza dia, kalau macam nosocomial tu, it gets from the hospital lah. Kalau baby tu got admitted in NICU ke apa. So contoh macam bila dalam NICU, so they have lots of macam parenteral lah, intubation lah semua. So the organisms come from there lah. Kalau macam, and then they usually happen early onset lah. Dia under early onset. And then kalau macam kalau macam community tu, maksudnya macam kalau dia daripada environment. Maksudnya kalau baby tu dah macam dah discharge kan, lepas tu kat rumah ke, dari segi cleanliness ke apa, so the organism will be different lah. So to the different
So early onset sepsis is a community acquired ke atau hospital acquired?
Early onset most of the time is it could be, kalau yang saya faham lah, kalau early onset ni most of the time dia yang during delivery ataupun yang
so
maksudnya kat hospital lah.
Ke? Is it community acquired ke hospital acquired?
I think it is nosocomial, maksudnya hospital.
Ya, so kalau perempuan tu beranak
kalau
kat rumah
nosocomial bukan biasa dia ada macam after 48 hours of hospital admission.
Oh ya, okay, lupa.
Okay, so in adult or in older pediatrics kan, when you say this is a nosocomial infection, contoh lah someone datang hospital, okay, datang hospital with sepsis, anyone lah, any age, datang in sepsis. So what is the criteria to decide what antibiotic should be given? Satu, of course, the source lah, sama ada this is pneumonia ke UTI ke, based on history and also clinical findings and also investigation kan. Contoh memang datang dengan dysuria, then you tahu this is UTI, so you bagi antibiotic that covers for common UTI punya organism. Okay. Tapi another thing you have to consider is whether this is hospital acquired ke community acquired. For example kan, you've got an old man kan yang daripada institution, contoh dia daripada rumah orang tua. Okay, has been staying in rumah orang tua, and then ada outbreak kat rumah orang tua tu, ada outbreak salmonella lah for example. And then datang ke hospital. So what sort of antibiotic you bagi kat dia? You akan bagi antibiotik yang will cover the common organism dekat center dia, faham tak? Dekat institution. Contoh dekat rumah orang tua lah. Contoh ada outbreak dekat rumah orang tua tu salmonella tadi kan. Then we know salmonella, then we treat with ampicillin should be enough lah untuk salmonella. So pakcik ni kita akan bagi ampicillin. Rather than kita bagi dia C-pen ke benda yang common yang kita guna kan. Sebab so that's what nosocomial is. If you got someone who is just been discharged about 1 week ago, pernah masuk hospital, stay for 3-4 days kat hospital, and then discharge, lepas tu datang balik after 1 week. So what antibiotic will you give to this patient? Datang pneumonia lah. So you akan bagi antibiotik yang cover common organism dekat hospital yang dia discharge, which is hospital acquired lah. So this is what we call nosocomial. Nosocomial means the organism is acquired from hospital environment. Because hospital environment, because the use of antibiotic, the invasive procedure yang kita ada, the central vettings, ventilation, the central ventilation system, oxygen yang kita ada. So all these equipments, all the environment will affect the common organism yang culturable lah, yang grow dekat that environment. So nosocomial means infection yang acquired from hospital. So early onset sepsis is from the mother kan. Mother ni duduk kat mana? Hospital ke duduk dekat community?
Community.
Community kan. So mother duduk kat community. So early onset sepsis is a community acquired infection. Okay, faham? Tapi macam mana kalau mother ni, if you got a baby with early onset sepsis, maksudnya dia lahir with sepsis, tapi mother ni contoh duduk dekat ICU. We know the mother duduk dekat ICU, kerja sebagai contoh cleaner dekat ICU, for example lah. Cleaner dekat ICU memang basuh najis patient lah, contoh kan dekat ICU. And we know ICU dia ada banyak MRO kan, banyak apa, SBL, bakteria-bakteria yang multi-resistance organism kan. Then the baby is early onset ke late onset sepsis? Is it nosocomial ke community acquired? Baby lahir with sepsis.
Nosocomial?
So it can still be nosocomial. So despite the early onset sepsis, it is early onset sepsis because it's occur before 72 hours of life kan, within the 72 hours of life. Tapi because the source, there is possibility that the source is actually from environment yang mother dapat in hospital. So this kind of baby we have to treat differently. Dia maybe kena cover with broader spectrum antibiotic yang slightly different. Tapi in general we know most mothers duduk kat community and not exposed to hospital punya organism. So early onset sepsis we can say as is a community acquired infection in neonates. Faham tak? So the treatment usually early community punya organism lah, treatment yang cover community punya organism. Except in some specific case lah, some specific case yang mother punya ada risk factors. Faham kan? That's why the hours tu is very important. Tapi those yang lahir after 72 hours baru dapat infection, then chances are they get infection from the environment. So kalau baby ni has been in the hospital since birth, okay, contoh lah baby dah in the hospital since birth, and then after 1 week discharge, contoh admit because of G6PD deficient, so admitted for 5 days for monitoring, observation for jaundice kan, and then balik rumah, day 7 datang dengan fever. So this is a late onset sepsis kan. What are the possible organism yang attacking this, yang infecting this child? You rasa lah, dia dah seminggu di hospital and then discharge and then come back after 2 days with fever. You rasa what sort of organism yang infecting this child?
Nosocomial kot.
Nosocomial lah kan. Sebab dia dah duduk lama kat hospital. So chances are dia dapat organism daripada staff nurse lah. Staff nurse tengok satu patient tak basuh tangan, tengok dia. Kan duduk kat ICU, duduk kat ICN, ataupun doktor lah, doktor yang memang pengotor kan, biasalah doktor memang tak basuh tangan kan. Macam I pun selalu tak basuh tangan. So you pegang satu patient and you pergi kat patient ni, you pegang. So you transfer the organism from one patient to another. Cross reaction kan, cross infectivity. So the child, that's why it's important to differentiate between early and late onset. Faham tak? So late onset, most of the time is acquired from environment rather than from the mother. And environment, it depends. Kalau dia ada history of admission, then possibly it's from the hospital. Kalau dia tak ada history of admission, tapi dia duduk kat community, contoh dah balik 2 minggu, lepas tu buat akikah, buat kenduri akikah, and then suddenly after 2-3 days, fever. So chances are dia dapat community acquired lah. Dia dapat environment acquired, tapi most likely daripada environment, daripada orang yang datang cium-cium baby kan. So dia dapat, most likely is dapat virus lah rather than bacterial. Atau kalau bacterial pun is common bacterial, just Streptococcus, benda macam tu lah. Okay, faham kan? Ada soalan tak? Okay, so usual presentation, okay, let's go to the slide. So the usual presentation is actually with septicemia, pneumonia, and meningitis. Kalau you tengok the early onset sepsis tadi, go back to the EOS tadi. Okay, usual presentation is actually respiratory distress kan. Dia akan datang dengan pneumonia. Kenapa usually dia datang dengan pneumonia most of the time? Kenapa dia tak datang dengan UTI? Atau dia tak datang dengan diarrhea, vomiting? Anyone? You guys dengar tak?
Dengar. Maybe
Alright.
sebab sebab kalau macam dia akan contact dengan mak punya genital tract ke apa kan. So macam those thing akan pergi dekat mucous membrane dulu and it can go to the lungs. And kalau macam in the problems yang macam chorioamnionitis ke apa, so kalau macam amniotic fluid tu infected kan, so dia macam direct contact with lungs of the baby.
Kenapa Okay.
Lepas tu,
Okay, good. Betul, good. That's true. So what happen is, usually baby kan dia lahir and then dia minum all the amniotic fluid, maternal blood kan. Sometimes they aspirate. So most of the time, the organism dah colonize dekat upper respiratory tract infection, upper respiratory tract, and then it goes down to the lower. So usual presentation will be pneumonia lah kan. Tapi in late onset sepsis, it can be variety. Okay, for example, dia dah lahir for 2-3 weeks kan, for 2 weeks lah, already delivered, already born for the past 2 weeks, and then dekat rumah basuh tak bersih kan, berak basuh tak bersih, just wipes and then tak bersih lah, wipes tak properly wipes, so get infection, translocation of infection from GI go to the urinary tract, so dapat UTI. You faham tak? So for late onset sepsis, there's a more the causes are more variety. Yeah, there are the range of causes here more lah compared to the early onset sepsis. So you don't get UTI lah as in early onset sepsis. So it's difficult untuk dapat UTI. Macam mana dia nak dapat UTI kan? Kan macam susah kan? So you don't get UTI in early onset sepsis, atau you don't get things like osteomyelitis in early onset sepsis. But in late onset sepsis, you will dapat osteomyelitis. For example, you ada masuk line kan, baby ni masuk ward, kita pun masuk line, and then kita ada thrombophlebitis. Kemudian from thrombophlebitis, dia pergi dekat the nearest bone, and then dia infect the bone, so dia dapat osteomyelitis. So in late onset sepsis, because the possibility of infection, the source of infection is variety, and there's a lot, so more extensive investigation has to be done. Okay, cuba go balik late onset sepsis. Next slide. Okay. So it can be, they can present with septicemia, pneumonia, meningitis, osteomyelitis, can come with anything from the sky. Okay, anything. Okay, and then so factors yang predispose, again, low birth weight, prematurity, late onset sepsis. Okay, next. Okay, and we know breastfeeding is protective because ada transfer of maternal IgA from the milk, and also maternal immune system immunity lah from baby tu, from mother to baby. Okay, next. Okay, next. Okay, sorry. Balik tadi. Okay, so the most common cause of early onset sepsis is infection yang organism that colonize the maternal punya GU tract kan, which is GBS, E. coli, gram negative. Okay, these are the most common. Okay, remember ni, GBS, E. coli, and gram negative. And some other organism that can actually cross placenta that commonly acquired. For example, macam Listeria. Listeria is easily acquired daripada milk kan, the dairy product. Herpes simplex kan. For example, mother ada genital lesion kan, the genital lesion, genital herpes. Then baby lalu kat situ, dia pun minum and then dia makan, dia contact with the lesion, so dia dapat herpes. And some ada lah enterovirus daripada GI tract. Okay, next. Okay, for late onset, GBS again dia boleh cause. Okay, this is one of the commoner cause of late onset sepsis, GBS. And then tapi dia lagi banyak viruses. Okay, they can get a lot of virus from surrounding RSV, influenza, COVID-19. These are the virus yang most of the time is actually community acquired. Okay, COVID-19 is community acquired. So biasanya patient masuk hospital will be screened so they don't get COVID in the hospital lah. COVID mainly is a community acquired. Okay, so kalau next time dalam exam you kata what is the give examples of viruses yang cause late onset sepsis, you can put COVID lah. Nowadays COVID is one of the commoner. Okay, community acquired. Okay, again the late onset is community acquired. So things like pneumococcus, meningitis, macam tu lah. Ada soalan tak? Nanti I share you the slides, you baca je lah. This I think quite simple. Just straightforward, you can just read. Okay, clinical features. Again, because sepsis in neonates is different than adult atau older children, because baby first they cannot mount inflammatory response, they cannot mount antibody response lah, cytokines response similar to adult. So rarely baby dia ada fever. Okay, so, most of the time they got hypothermia rather than fever, because dia tak boleh 10:45. Ambil ni. Ambil ni. So apa tadi? Yes. So symptoms is very vague. So baby dia tak boleh produce fever, kan? Dia interleukin, cytokine semua quite immature. So they rarely have fever lah. The usual features is lethargy, poor cry, poor feeding, hypotonia. Sometimes just metabolic acidosis, nampak colour dia lain sikit. Okay. And also it depends on the source of infection. Kalau contoh dia ada meningitis and dia ada bulging anterior fontanel, and then irritability, high pitch cry. Kalau this is a infection from the bawah. Sorry, bawah lagi. Next. Okay, next. Okay. So GI dia akan ada feeding intolerance. Kalau hepatic ada jaundice, severe jaundice. Ada tu lah. These are the features lah. Next. Okay, next. Okay, so investigation you can buat definitely blood culture. Okay. So before you start any IV antibiotic, you can ambil blood culture lah. Okay. But remember, negative blood culture doesn't mean the patient has no sepsis. Sepsis is diagnosed clinically, bukan by investigation. Next. And then all septic screen. For early onset sepsis, as I mentioned, most of the time they come with pneumonia. So the investigation is rather limited. You don't do extensive, not as extensive as late onset sepsis. So in general, you don't actually do lumbar puncture, you don't do urine culture, you don't aspirate joint aspiration. This is not something routinely done in early onset sepsis, because again, most of the time the source is actually you punya upper respiratory tract and also lower respiratory tract. Okay, tapi for late onset sepsis, it can come from everywhere, so you have to do extensive. Usually patient come with late onset sepsis, sepatutnya you kena buat LP, lumbar puncture, kena ambil urine, kena do all the radiologies, investigation, radiological investigation, anything lah, depending on your degree of suspicion. Okay. And then blood investigation macam biasa FBC semua tu lah. Next. Okay, lumbar puncture. Okay, but remember, okay, clinical practice is different in different clinical setting. In our center, we look at CRP. Kalau CRP high, our practice in NICU, even though this is early onset sepsis, baby with high CRP kita ambil juga LP, because we believe bila high CRP means the infection has been ongoing since in utero, kan? So there's a lot of time untuk the bacterial to translocate from the respiratory tract, goes up to the brain. Okay, reflected by the high CRP. Okay, faham kan? So tapi ni clinical practice. But in theory, we don't do LP in early onset sepsis. Unless high degree of suspicion. Okay, lagi. Next. Okay lah, pasal next. Okay, pasal next. You boleh baca CSF. Radiology, okay, again, chest X-ray in early onset sepsis. Because sometimes baby with pneumonia, they may not present with tachypnea or respiratory distress. Sometimes they present with bradypnea, sometimes they can present with apnea, or even they can present with lethargic. Okay, may not have respiratory sign. Tapi chest X-ray is indicated. Okay? Chest X-ray is very important. Especially kalau ada respiratory features, then you kena ambil buat chest X-ray. Kalau tak ada, then it's okay lah, it doesn't matter. Maybe you tak perlu buat, tapi you kena buat ada blood investigation lah. Kalau contoh, for example, you've got a child yang at birth, very lethargic, poor sucking, then you have to do blood test lah, check FBP, FBC semua. And if there's evidence of infection, but you don't have the source, then you may need to do chest X-ray to get clues where is the source of infection. Because again, pneumonia is the most common source of infection in early onset sepsis. Okay, next. Urine culture, again, we takkan buat in early onset sepsis, except for some people, they do it. Okay, next. Okay, next. This is LP lah. Okay, LP, I don't think this is important. You boleh baca sendiri. I'm not interested in herpes. Okay, next. Okay, management. So do all other sepsis punya management, like adult or pediatric. It's all about supportive lah. Yeah, we call it expected management. Cuma in neonates, because neonates is a immunocompromised population. It's very immunocompromised. So you have to act quick. Okay, start broad spectrum antibiotic. Usually we don't use broad spectrum lah. We use 2 narrow spectrum antibiotic that covers gram-negative and gram-positive. We use empirical antibiotic. Empirical means, empirical is not prophylaxis. Prophylaxis ni dose yang tak ada sign, you start. Okay, empirical antibiotics is, you start antibiotic before you've got the culture, okay, before you got the definite diagnosis, you start empirical antibiotic, you start antibiotic based on the most likely organism. Okay, so macam I mentioned tadi, I bagi satu scenario yang mother dia kerja kat ICU, cleaner, bersihkan stool semua of ICU patient kan. Then this kind of patient, empirical antibiotic dia maybe tak sama, walaupun dia datang early onset sepsis, but the empirical antibiotic might not be similar as those baby yang mak dia kerja kerani dekat luar and then come for delivery and then suddenly born with sepsis. So it'll be different, okay? Because one got from community, one got from hospital nosocomial. Most likely from nosocomial lah, from ICU. So that's what we call empirical antibiotic. And then again, the choice is depending on your clinical judgment. Duration also depends on the source. Okay, if you think this is meningitis, then you have to treat longer. Kalau you think this is for osteomyelitis, then you need to treat longer. Okay, kalau just straightforward. But usually, kalau patient yang confirm sepsis, confirm means culture positive, then you have to treat for at least 1 week. Okay, kalau confirm culture positive. But if culture negative, you have to base on clinical judgment. Okay, by investigation, also by clinical patient clinical progression. Okay, so usually 5 to 7 days at least. Okay, next. So this is the usual duration. Next. Okay. So like I mentioned, okay, with patient with confirmed diagnosis of sepsis, then we call it antibiotic lah, antibiotic treatment, curative antibiotic treatment lah, targeted antibiotic treatment. But those yang without culture positive, which most of the time we have to start before waiting for the culture results. So culture takes about 3 days. So with any degree of suspicion for sepsis, then we have to start empirical antibiotic. Then, but you need to decide, you need to understand, or you need to recognize what are the signs and symptoms, what are the risk factors. So any babies, because this is immunocompromised population, any babies with all the risk factors or any of the risk factors with the clinical sign or features suggested for sepsis, you can start antibiotic. Okay, so this is the rough guideline lah. But in general, even with slight degree of suspicion, contoh you rasa macam, asal baby ni macam weak, nampak lethargic, saya tak nampak normal macam baby lain, start je antibiotik. Doesn't matter. Okay, because degree of suspicion, any degree of suspicion is an indication to start antibiotic. Because in patient with immunocompromised state, kan, you have to start early, you can stop early, tapi you have to start early. You don't wait until full blown sepsis. This is applied to patient yang macam immunodeficient, patient yang on ongoing chemotherapy or radiotherapy, on high dose steroid, yang memang immunocompromised. You don't wait for them to get fever, or you don't wait for them to get full blown sepsis or culture positive. You just hentam je with empirical antibiotic. Okay, next. Okay, prophylaxis again saya mention tak ada. Next. Empirical, okay, next. Okay. So, okay, usually kalau community quiet, we know the common organism alone sepsis is GBS kan. So GBS you bagi penicillin lah. You bagi narrow spectrum penicillin macam ampicillin or C-pen, benzyl penicillin atau amoxi pun tak apa. Okay. And then the second most common is E. coli kan. Then E. coli you have to cover with antibiotic yang cover narrow spectrum, antibiotic yang cover gram negative. A good one would be the aminoglycosides macam gentamicin. That's why we usually start dengan MP-Genta or C-pen-Genta. Okay, kalau we reserve some antibiotic for hospital acquired. Contoh macam mother tadi kan, mother yang kerja kat ICU tu. Then you may need to start things yang cover Pseudomonas. It's common in ICU kan. So Pseudomonas you bagi ceftazidime. Rather than you start with ampicillin, you start ceftazidime. Ataupun tapi you kena cover juga some other yang antibiotik yang cover for ESBL ke, then you start aminoglycosides yang higher, contoh macam amikacin. So these things has to be discussed between with the neonatologist and also your ID specialist now. Okay, next. Okay, ada soalan yang tanya tau. Okay, next. Next. Betul. Next. Ni baca sini. Next. Okay. Okay. Ni you baca lah. Bukan bosan. Next. Okay, herpes. Again, herpes has gained a lot of attention because the outcome is very bad. Okay, herpes infection is very bad and it's quite common lah. For viral infection, herpes is one of the most commonest, and most of the time it presented in 3 ways. Okay, herpes usually either they come, baby will presented with SAM, skin, eye dengan mouth disease with lesion, ataupun they come with bacteremia, full blown sepsis, or they can come with meningitis. Okay, but however, again the prognosis is not good if untreated. At least the least will be death lah. The least will be death. The majority of them will become vegetable lah kalau you tak treat. That's why it's very important to have a degree of suspicion of herpes infection. That's why you have to take, if you have degree of suspicion that this is herpes, for example, patient presented with these 3 presentation lah, either skin, eye or mouth, ataupun sepsis or encephalopathic kan, nampak seizure for example, meningitis, and then mother pun ada lesion ataupun nampak macam suspicion lesion kat mother, then you may need to consider start empirical acyclovir to cover for herpes. Okay. And usually dia ada clues lain lah, contoh macam liver derangement, thrombocytopenia, rashes, things like this lah. Okay, next. So herpes again we treat with acyclovir. Okay, next. Okay, next. Okay, next. Sekejap balik sampai sana. Okay. Usually HSV ni, like I've mentioned lah, dia ada 3 presentation. SAM is the most, the earliest presentation will be the SAM disease lah. Okay, and then you've got the meningitis after, usually baby come herpes that presented at the first 1 week of life, macam tu biasa datang dengan SAM ataupun sepsis lah, sebenarnya full blown sepsis. Kalau yang datang later tu dia akan datang dengan meningitis. Sama macam GBS. Okay, GBS that come early, the early presentation of GBS is pneumonia. But if the GBS kan dia tak manifest, dia duduk, dia relax tu dekat baby punya badan. Usually they present later about 3 weeks or 4 weeks of life with meningitis. Okay, next. Ini SAM lah. Okay, tu ada skin lesion, ada mouth. Okay, next. Bosan. Next. Bosan. Okay, bosan. Next. You kena tahu, by the way, yang I kata bosan tu doesn't mean you tak payah tahu. You kena tahu, cuma I tak suka. Next. It's not that important lah. Macam ni, this is not important lah for you guys, but it's good for you to know. Okay. Typical CT or MRI imaging for herpes encephalitis. Okay, they usually presented with this lah. Lateral flat, posterolateral epileptic. Yang tu EEG, that is epileptic discharge. Kalau MRI ni, I can't remember lah the term. Anyone know the term call lah? Sekejap. Anyone know the term for this sign? Anyone? Apa lah nama dia? Lateral. Sekejap nak check. Kalau in EEG, we call it PLAD, posterolateral epileptic discharges. Okay, this is quite typical of ni lah. Quite pathognomic for herpes. Jadi kalau ni, I can't remember lah. Tak apalah, nanti baca lah. Okay, next. Okay, treatment, acyclovir, next. Okay, ada infection also is important, especially the torches and also varicella lah, chickenpox. Okay, congenital chickenpox, perinatal chickenpox is very dangerous. Okay, if a baby, if mother is seronegative, maksudnya mother never been infected with chickenpox and then got chickenpox at the first trimester, okay, baby can born with amputation lah. Dia akan datang dengan limb defect, deafness, dia boleh lahir dengan that features lah. It's very dangerous to baby. Tapi kalau infection occur in the 3rd trimester, that's the worst. Okay, mortality is very high. Mother infected at 3rd trimester towards delivery, that has the worst prognosis. Sometimes kalau dia occur kan, kalau mother get infected during the 1st trimester, baby boleh lahir with skin lesion. Dia boleh lahir dengan scar. Dia akan lahir dengan scar. You akan nampak scar chickenpox. Lahir-lahir ada scar. Because dia dah dapat chickenpox in utero. Because biasalah memang dia very small RNA virus, dia cross placenta very easily. Okay, and sometimes this baby, you tak tahu pun dia pernah ada chickenpox. Bila lahir dia tak ada chickenpox, tapi actually in utero dia dah ada. And then after a while kan, sometimes bila dah besar sikit, bila ada immunocompromised, for example, dia dapat diabetes ke ataupun dia dapat on chemo ke, dia akan datang dengan shingles. Dia akan appear with shingles lah, with herpes zoster. So it's a sign, it's a proof that dia dah pernah kena in utero infection. But anyway, varicella is very important because the management will be different. You kena bagi, kalau mother ada baby high risk of perinatal, memang baby ada perinatal acquired varicella zoster. For example, mother ada lesion infected the first 5 days before delivery ataupun 1 week after delivery, then baby has to be given Vesa-Zoster immunoglobulin and also acyclovir lah. And then toxoplasma again, toxo, rubella, all these tortuous infection, if it occur in utero, then it will be very dangerous, especially the third trimester. Tapi kalau baby dah 2 bulan, for example, baby dah 2 minggu, 3 minggu, and then infected with toxo, most of the time it's just mild infection, it doesn't cause anything lah. It's not dangerous. Tapi kalau occur in utero, it can be very dangerous. Okay, but problem is we cannot treat toxoplasma. In the past, we do treat toxoplasma with some medication macam Pansida semua tu. But nowadays, we don't have that medication. Okay, the whole Malaysia tak ada lah medication untuk treat toxoplasma. So, baby yang ada toxoplasma, we just follow up. Just wait for the consequence lah. Macam deafness, blindness, hydrocephalus, things like that. Rubella against cause PDA, in utero infection of rubella cause PDA, and also limb defect, deafness and so on. Okay, next. Okay, good. Okay, sekejap. Nak habis dah? Okay, got questions?
Doctor, I have
Doctor,
several questions.
Okay.
Okay,
boleh.
Adila first.
Okay, my name is Adila. So I have several questions. My first question is, so in neonates ni dia tak ada macam sepsis criteria macam dalam adult lah, doktor. Maksudnya just on general suspicion
Yes.
dekat vague
Yes.
symptom je lah.
Yes,
Okay.
betul.
So my
Because
second
again
question.
lah, you tak boleh tunggu. For example, CRP.
Okay.
What is CRP?
Inflammatory
What is
marker.
CRP? Okay, how do you produce CRP? CRP produced by your liver. It's not produced by the organism. It's produced by your liver. So kalau baby with immature liver kan, let's say premature baby, they rarely get high CRP. Sebab because the liver is too premature untuk produce enough CRP. Ataupun ESR, ataupun ada inflammatory markers. Contoh total white, the marrow might be too immature, especially baby yang SGA yang small kan, yang small. So this baby maybe they won't have the typical features of sepsis. Okay, in fact they may have reverse. Contoh macam hypothermia, bradypnea, apnea. These are not common in typical sepsis lah in adult or older children. Okay, next.
Lepas tu doktor, kalau kita suspect sepsis je, kita manage dekat ICU ke boleh dekat
Dia
ward
mesti
biasa?
kena ICU. Mesti kena ICU.
Okay.
Okay,
My third
first,
question. Okay.
if you ada degree of suspicion kan, you suspect this is sepsis, and then once you start empirical antibiotic, you mesti monitor dekat ICU. Okay, and then after 1 day nampak okay, improve, clinical pun nampak tak ada benda, it's just a presumption of sepsis rather than a true sepsis, then you can transfer ke ni lah, ke SCN untuk continuation of antibiotic. Okay, next.
Okay, my third question is dia ada tak kita apply macam sepsis bundle macam dalam adult tu ke
Ada.
just antibiotic je?
Okay, there's a lot of bundles lah. Apa bundles ni? Sepsis bundles ni apa? What is bundles?
Dia ada series of yang benda kita kena buat within
Good.
specific
Yes,
time.
that's very good. Okay. So in neonates also we've got bundles, but these bundles are more to sepsis prevention. Contoh in neonates kan, contoh bundles included in the sepsis bundles in neonates. And this is usually based on ICU basis lah, at the level of ICUs rather than national levels. So most bundles kan yang kalau neonates contoh for example central line punya care. Central line tu kena tukar dressing berapa crowd. And then who should do the central line? Is it the senior most has to do the central line. And then kalau intubation, what is the procedure in intubation to prevent sepsis? And then the type, hand hygiene kan, hand hygiene, the use of apron. But again, this varies between ICUs lah. But there are bundles. Contoh the use of antiseptic. What antiseptic should be used untuk normal culture, untuk regular culture, peripheral culture, untuk central culture. So these are the different the bundles lah. Dia bukan macam adult. Adult they are because there's a lot of study in adults which cannot be done in neonates, in children and neonates. Macam in adults kita tahu the first 1 hour kena buat apa. You ada kan that early directed goal in sepsis kan, EGD apa dah saya tak ingat dah. Kan?
Betul.
Macam the first 1 hour you kena apa? The second 2 hours lactate kena normalize. The first 4 hours lactate kena normalize. You kena ada PCT bla 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 bla. Okay, anyway. So next. Lagi?
Doktor, saya nak tanya, yang tadi yang gambar yang ke imaging tu doktor. Sob
Gambar
dulu
mana?
kat gambar imaging tak sob? So that one ni doktor, this is considered as a CT kan doktor?
Yang ni CT. Yes. This one is...
Lepas tu tadi doktor cakap, kalau tadi doktor cakap kat sini tak payah tahu
MRI
sangat,
ni.
tapi doktor kata MRI. Lepas tadi yang tadi doktor cakap, apa ni, kena tahu yang kat tepi ni dia yang nama dia encephalomalacia ke, sebab dia ni kita panggil extra limbic involvement ke macam mana doktor kita nak cakap?
Dia bukan extra limbic involvement. Extra limbic involvement dalam apa? Extra limbic involvement dalam
sebab
apa?
yang saya baca dekat yang kan yang untuk children common dapat extra limbic involvement in compared to the adult. Kalau yang adult nanti dia ada yang limbic system, temporal lobe, insula corticus semua tu involve. Tapi kalau yang
untuk
in
HSV?
children, ya saya doktor, saya tengah buka HSV encephalitis sebab tadi doktor cakap kan. Lepas tu yang ni dia kata extra limbic involvement. Kalau lah misalnya kita dapat benda orang ni tanya tapi kita orang tak tahu nak cakap apa, can we just say that memang dia kat luar kan extra limbic, or can we just say it is an asymmetrical dekat parietal lobe, something like that. Is it possible doktor?
Biasanya ala kalau soalan exam dia kan, so you describe lah apa yang you nampak, doesn't matter.
Faham?
I don't think any of the pediatric, any of us tahu pun this is extra limbic.
Kita, sorry doktor.
Because in pediatric, memang HSV is common, tapi the presentation typical macam adult, dia tak datang macam tu in pediatric.
Faham. Doktor, ada dua soalan. Saya nak clarify balik sebab tadi macam ada yang tercepat sikit tapi internet saya slow. Tadi doktor kata kalau orang yang sepsis, kalau kita sepsis ni by clinical kan doktor? Kalau orang tu kita confirm sepsis, kita terus start antibiotik for at least 1 week. Lepas tu tadi doktor kata kalau dia punya blood culture dia negatif tapi kita suspect ada sepsis, kita bagi treatment for a week juga. Doktor?
Okay, tak, dia macam ni. Dia bila you suspect kan, that's why we've got the diagnosis of presumed sepsis. Okay, you may dengar kan diagnosis presumed. Presumed is when we suspect. Presumed sepsis is any baby yang kita suspect got sepsis. Okay. So presumed sepsis contoh dia macam dia ada different diagnosis. First is presumed sepsis. Okay, presumed sepsis
Doktor tak dengar, you cannot hear you.
dengar. So I mute. Okay, so presumed sepsis is any baby yang ada risk factor for sepsis tapi without any evidence of sepsis. Maksudnya dia tak ada clinical features of sepsis. Dia tak letargic, dia aktif macam comel lah, macam baby biasa. Tapi got risk factors. Okay, these are the babies yang kita presume sepsis. So we start treatment early, antibiotic early, while investigation ongoing. Faham tak? Before you investigate, you start antibiotic. Because you cannot take risk. These are immunocompromised babies, kan? So you start antibiotic and then you investigate. Okay, once you complete your investigation, contohlah, you tengok FBC normal, CRP normal, everything normal, then you observe for at least 24 hours, nampak baby well, then you boleh stop antibiotic, discharge lah.
Faham. Lepas tu doktor yang kita cakap start antibiotik tu yang tadi doktor ajar lah, yang empirical tu, yang coli, GBS semua tu kan tadi doktor?
Yes.
Okay, faham. Lepas tu saya nyari hati ni, saya selalu daripada ONG pun saya rasa macam kita orang macam kurang sikit. Tadi doktor dah sebut yang varicella zoster tu kan? Lepas tu tadi yang doktor kata betul lah, yang untuk trimester tu lagi teruk lah. Lepas tu yang saya tak dapat, doktor kata tadi kita treat dia dengan bagi acyclovir dengan immunoglobulin tu, masa dia dah nak bersalin hujung-hujung tu dengan selepas tu macam mana?
Kita bagi baby. I tak concern mother lantar tak lama ada. We just give
Oh,
baby.
faham. Jadi kita bagi
Ah.
baby untuk dalam berapa tempoh doktor? Kebiasaannya approximate ke benda tu depend?
Maksud dia berapa tempoh ke? Duration of.
Ya, immunoglobulin tu nak bagi, acyclovir tu nak bagi.
Oh, yang tu
Mm-mm.
immunoglobulin you bagi sekali je. Acyclovir you bagi usually for 2 weeks.
Oh, macam tu. Okey doktor.
Acyclovir 2 weeks. Cuma sometimes kita bagi macam 1 week IV and then the rest bagi oral. Tapi it has to be 2 weeks. Kalau confirm, it has to be total of 2 weeks lah. Tapi the more importantly is the immunoglobulin. Actually once you bagi immunoglobulin, acyclovir tu is just for supplement je.
Lepas tu dengan doktor kata kalau orang yang late onset tu memang kita kena buat a serial of investigations lah kan. Lepas tu untuk yang
Yes.
monitoring baby ni doktor, contohlah macam in view of LP lah kita buat. Lepas tu ada tak kita repeat balik benda lah tu doktor? Ke it's just like one shot at the initial
one shot.
investigation, that's it?
Dia macam ni. You just
macam
buat
tu.
sekali je. Okay, you buat
Faham.
sekali for diagnosis. Okay. Tapi kalau doesn't work, contoh you bagi antibiotik doesn't work, actually you kena repeat.
Oh, macam tu. Okay,
Okay.
doktor.
Contohlah you buat LP and then confirm this is meningitis. And then you bagi antibiotik, doesn't work. Still fever, still got the CRP still high. Tak ada improvement. Then you kena repeat. Okay, but problem is our culture is in our culture nak buat satu LP pun susah.
Betul.
Nak dapat consent susah kan. So what more nak buat 2-3 kali. So usually what we do empirical, we give empirical antibiotic and wait for the culture. Once we got the culture, we know the organism, then we treat. Tapi kalau tak ada culture negative, tapi patient tak respond, then we just move lah. We just escalate antibiotic to the second line, third line, fourth line and so on lah.
Doktor. Okay, doktor. Terima kasih doktor.
Okay, semua lagi?
Doktor, I have question. Ada dua sebenarnya. Okay, satu question tu, contoh macam kita ada baby, dia dah masuk NICU. Lepas tu ada, biasalah bila masuk NICU banyak yang kita akan letak jarum-jarum semua kan. So, tiba-tiba patient develop macam sign of sepsis. Lepas tu kan kita kena bagi antibiotik kat baby kan. And at the same time, kita kena cabut ke benda tu?
Okay, dia macam ni. Kalau dia just peripheral line, usually kita tak cabut. Because we know the risk of infection from peripheral line is very low. Okay, and peripheral line should not be remain in situ for more than 3 days. Okay, kalau 2 days, kita kena remove lah. Okay, tapi kalau we are talking about central line, okay, central line means long line ke, femoral ke, central line umbilical catheter ke. Okay, sepatutnya kalau dia ada infection and we got suspicion that this, we highly suspect that the source of infection is the central line. Okay, what we call CLAPSI or CLBSI. Doesn't matter lah what you call it kan. Definition is different tapi it depends lah what you call it. So sepatutnya you kena remove the central line. Sepatutnya you remove the central line. However, in most center, because most of the time kenapa patient on central line? Because difficult line. The second, because they need the central line. Contohlah, you got a baby kan yang require like 6 weeks antibiotic. And then the first 1 week tu, the first 2 weeks you cocok. Kan dah tak ada line. So you decided untuk masuk central line. So you masuk central line. After those, there's no more lines, so ada satu je line, you masuk central line. And then suddenly after a week, dia ada sign of infection and you think the source is the central line. So will you remove the central line? No lah. So, kalau you remove central line, you nak cocok mana pula antibiotik kan? So what happen is, usually we will cover with antibiotic, we keep the central line, we cover with antibiotic and then see the response. Kalau respond, and in some center, what we do is we do antibiotic lock. Okay, usually because we know you need to have some degree of suspicion lah. Contoh, if you think this is the central line is the source of infection, then you know most of the time is MRSA lah yang you takut kan. So you boleh bagi vancomycin lock. So you lock the line tu dengan antibiotic and give time. So relaxkan, rest the line for like 1 or 2 days or few days and then you use back the line. Ataupun you boleh lock dengan alcohol ke, things like that, ethanol. So different method of locking lah to preserve the central line. But ideally, kalau contoh soalan exam keluar, you remove the central line. Okay. Kalau you suspect any line related infection, remove the line and treat with antibiotic. Okay. Tapi in clinical setting, we don't actually remove line except kalau memang dah soil gila, memang rasa memang that's the source lah, memang tak boleh control the infection, then you have to remove it. Ataupun you can get an alternative line. Itulah. Okay.
Okay, lepas tu, faham. Okay, thank you. Lepas tu, yang tadi yang doktor sebut presume sepsis tu kan? That one sama macam probable lah kan? Probable sepsis kan?
Tak.
Sama lah kan? Tak?
Tak sama.
Oh, tak sama.
Tak sama. Okay. Presume sepsis is presume. You assume. Okay. Probable sepsis is when the child got clinical or any investigation, biochemical or clinical sign of sepsis. For example, you ada baby, dia ada risk of sepsis atau tak ada. Doesn't matter. Contoh baby tu tak ada risk of sepsis, tapi lahir-lahir, lethargic, ada apnea. Then this is probable sepsis. Dia ada features of sepsis. Faham tak? So those with probable sepsis, you kena treat longer lah antibiotic. Because this is not assumption. This is something yang a degree of suspicion is higher. So kalau patient with probable sepsis, atau the usual term yang some people use is clinical sepsis, okay, clinical or probable sepsis, then antibiotic will be definitely 5 days at least. 3 to 5 days lah sepatutnya. Okay. Kalau presume sepsis, and then after you investigate, observation semua tak ada features of sepsis, and then investigation semua negative, then you off je lah antibiotik dia. After 24 hours ke, 48 hours ke. Tapi kalau contoh baby ni, dia well, cuma dia ada risk of sepsis, so you take FBC, you take CRP, and CRP dia high. Then this is called probable sepsis, then you need to treat at least 5 days. Faham tak?
Okay, faham.
Okay, faham kan?
Doktor, sekejap. Lepas tu kan, yang pasal MRI, betul lah MRI ni, yang doktor terlupa tu subacute hemorrhage ke? Yang hyper intense. Yang tu ke yang doktor cari tadi?
Tak. Dia ada term dia.
Oh, okay.
Dia macam ni lah. Dalam EEG kita panggil dia PLAD. Posterior lateral encephalopathic discharge. You tengoklah, dia kan posterior lateral. It's actually lateral kan? The lesion is actually at the lateral. So bila you buat EEG, you akan ada discharge at that area. Okay, that PLAD we call. Tapi kalau dah MRI, dia ada something different. Tak ingat lah nama dia. Tapi tu
Okay, thank you doktor.
Bacalah. Okay. 3 lagi saja. Okay, tak ada soalan dah. Saya pun penat nak jawab. Okay lah, I rasa kita stop no. Any questions you can just text me lah, WhatsApp. Okay, kalau I respond, kalau tak you baca sendiri lah. Okay, any last question ke? Or anything to say? Comment ke? Okay lah. Okay, so kita tanggung dengan tasbih kafarah.
Thank you, doktor.
Thank you, doktor.
Thank you doktor.
Thank you, doktor.
Thank you, doktor.